Добрый день.
Good day, colleagues, friends, and guests. Permit me to start our today's event. On behalf of the Children's Hematology and Cancer Hematology Oncology, we'd like to introduce our guests from Europe in Uzbekistan, our partners, and all the participants of today's event. We're here to gather, which is very principle for our sphere, palliative care and patient-centered medical service, focus on quality of life. For our Center of Hematology and Oncology, it's not a final step, but it's a system treatment. It's a support of children and family throughout their life. It's a control of other symptoms, psychological support, communication with the family, teamwork, and of course transitioning and all the treatment. Today's event is organized with the Center to strengthen our one understanding of standards of palliative care oriented on patients and family. We believe that on the result of the session, we'll have the concrete understanding of our next steps, what we can implement now in our clinical practice, what kind of instruments and protocols are need to be adapted, and what kind of training centers we have to continue in 2026. We'd like to express our gratitude to our speakers and support for their work in Uzbekistan. We understand their involvement in the job we do here. We'd like to also wish you a productive day. After the main event, we'll also want you to start fixing the questions and your proposals. It's very important our discussions will end in a productive tone and with our future, our actions. If you permit, I would like to also present our dear guests. Today, we have the speaker. It's very honorable for us, Dr. Michael McNeil. He's a master's degree in the healthcare system. He's a member of the Global Pediatrics in St. Jude's Children's Research Hospital and the director of the St. Jude Children's Hospital. Please welcome him. And we also have Dr. Julia Ling. She is an expert in the palliative care. She also participated in the conference on palliative care for adults and children organized in the European World Health Organization, where she presented the palliative care in the eastern part of Europe. Julia Ling works with the technical specialists in palliative care in the Department of the Regional System of European Regional Bureau of WHO in Copenhagen, Denmark. And we also want to start and invite Dr. Michael McNeil for the first presentation.
Wonderful. Good morning. Thank you so much for the opportunity to be here with you today to talk with you about palliative care, and in particular pediatric palliative care and its integration into the care for children with cancer specifically. So the objectives that I have for today are three. One, identify and define what is palliative care. Two, highlight specific elements of the integration of palliative care for children with cancer. And three, thinking about how we can build that into our treatment. So the first is, what is palliative care? And I love this definition from the World Health Organization in 2018 that defines that palliative care is the prevention and relief of suffering. This suffering can be for adult and pediatric patients, and it's associated with life-threatening or life-limiting illness. And these problems include physical, psychological, social, and spiritual suffering. And this is something that has been identified by the World Health Organization and other governmental bodies as an ethical responsibility and an ethical duty of healthcare professionals to alleviate pain. I can see it okay. Yeah. And so this is something that often I describe this where I'm a pediatric oncologist and a palliative care specialist, right? And so I split my clinical duties at St. Jude, both with our pediatric oncology team, but also our palliative care team. And so when I'm on service as a pediatric oncologist, I treat cancer. And when I'm on service as a palliative care specialist, I treat suffering, and how to be able to incorporate this. And so how do we prevent and relieve suffering? And so recognizing, again, this principle of what is called total pain. This is really coming from Dame Cicely Saunders, who is the founder of the modern palliative care movement. And it's the recognition that when our patients are suffering, it's not just physical suffering, that it's also the psychological suffering that they may be experiencing, the social dynamics of suffering, and even the spiritual or the existential suffering that might be occurring. And so when we think about how we take care of our patients, it's essential that we think of all of those elements. Even if we have the right dose of the right medication, even if we have the right administration, we still have patients that suffer, and we might see that they still have other elements of care that are required for them. So in the end, palliative care is the active total care of the child and the family, aimed at improving quality of life. It occurs from diagnosis from any patient to address patient and family suffering. And by nature, because we're not just dealing with the physical symptoms, but also thinking about the psychological, the social, and spiritual, it is essential that we do this in an interdisciplinary team-based approach, that this is interprofessional by design, that we work together as teams, as nurses, as physicians, as social workers, as psychologists, all with that goal to be able to improve the care of the patient and their family. Often we hear this, is that, well, isn't palliative care the same as end-of-life care or hospice care? And they're distinct entities. And so I like this figure a lot because it helps really understand the different components of palliative care. And so this was published in The Lancet in 2008 and shows that palliative care comes from the very beginning, from when a child or patient is diagnosed. And it requires this individualized blending of care directed at the underlying illness as well as these emotional, social, and spiritual factors. And that it requires continuous evaluation and reevaluation. End-of-life care is a component of what we do, and hospice care is a component of palliative care. But then also even after, with bereavement care of the parent's caregiver or the patient's caregivers, and throughout all of that, hope is a core component of this. And so I like this figure a lot because it provides that founding, but I like this one even better as we think about the integration of palliative care. And it used to be the top figure where it's, all right, we're working on cure, and then at some point we switch to palliative. But then it started becoming more of a parallel approach where we're slowly integrating more and more of palliative care earlier on in the treatment in this transition as our goals of care change. But I really love is this bottom figure, this idea of the integration, and this idea of curing and healing. And these are words that in the English language have some distinct connotations, and that's what brought me into palliative care to begin with. When I entered medical school, I was sure I was going to be an orthopedic surgeon. I played basketball and American football growing up, and I loved sports. And I also broke a lot of bones and I tore a lot of ligaments, and I was not very good at these sports. And so I knew very quickly that I was never going to be a professional athlete. But I thought the next best thing would be to be a professional team doctor, be a physician for these professional sports teams. And so that's what brought me into medicine in the first place. Luckily, when I was on my pediatrics rotation, I was assigned to be a part of the Pediatric Oncology unit and be one of the medical students helping take care of these patients. And I fell in love with the medicine. I thought pediatric oncology was fascinating with these innovations in technology, in chemotherapies, in immunotherapies, in the treatment of the patients. I also happened to have a son at the time, and our oldest son was about 9 months old. And we had a patient on the service with us who was also 9 months, who had infant leukemia that was relapsed and refractory to treatment. And after another treatment course didn't go the way that we hoped, the family decided to return home for end-of-life care. And as a new father, I was really struggling with that. And just like, what would I do if that were my son? How would I manage that situation? And luckily, my mentor at the time was dual trained in pediatric oncology and in palliative care. And he said, Mike, there's a difference between curing and healing. There are patients that we will not be able to cure, but there's always room for healing. And on the flip side, there are patients that we will cure of their disease, but they will never be healed of it. And that was such a profound revelation for me for what it means to be in medicine, what it means to be a physician or a nurse or any sort of healthcare professional. And the fact that our role is not just to cure, but also to heal, to support and strengthen these patients and families through whatever challenge they might face. And so I'm very grateful that I'm not an orthopedic surgeon today. I think I would have had a great time doing that, but I'm so grateful that I get to do this career and be a part of how do we think about incorporating high quality palliative care to reduce and alleviate suffering for children with cancer and other catastrophic diseases. So shifting gears, where are palliative care services offered? This is another element that I love about palliative care, is that we're not confined to the walls of a hospital. That yes, we can provide it in an inpatient space, but we can also be in a clinic. But we can also find ways to work in the home and in the community, or even a dedicated hospice space. But really the goal for palliative care is to make sure that we help provide the care that these patients and families need where they want to be for as long as is possible. Now, who can provide palliative care to patients and families? So often we talk about the differences between primary palliative care and specialty palliative care. Primary palliative care is that basic management of pain and symptoms, understanding of depression and anxiety, and those communication skills to talk about prognosis, treatment, suffering, and even advanced care planning. While specialty palliative care is really thinking through the refractory pain and other symptoms that are there, the management of more complex psychosocial needs, and then really thinking through some of those complicated communication strategies with situations that are tenuous or distressful. And so this is something that we continue to kind of learn and grow, but really when we think about this, every person who cares for children with cancer should have a basic understanding of pain management or psychosocial needs and how to communicate with patients and families. And so when I think about who can provide palliative care to patients and their families, it really is everyone. All of you in this room who care for children with cancer should have a foundation in palliative care. And to think about how we can then incorporate that into our practice and work with those specialty palliative care providers for some of the more complex needs. Now, why is palliative care so important for children with cancer? It's because these patients suffer. This was a foundational manuscript and published in 2000, so now 26 years ago, by Dr. Joanne Wolfe out at Boston Children's Hospital. And what she did was look at patients with cancer at the end of life, what were the symptoms that they experienced. And you can see that there was significant symptoms from fatigue to pain to shortness of breath to appetite to nausea and vomiting. But I think one of the things that was the most impactful for me in this figure is this bottom figure down here, where this was the number of patients that were treated, the percentage, and how successful that treatment was. So for example, for pain, 80% of patients were treated, but less than 30% found relief. So this was 26 years ago, and we still have a long way to go to make those improvements to make sure that these patients get the treatment that they need and deserve. This is that same team about 15 years later, and we got better and better understanding what those needs are and seeing the high distress that all of these different symptoms are associated with. And so really, we recognize that children with cancer suffer, and the next question then is, does palliative care actually help relieve that suffering? This was a systematic review published in the Journal of Pain and Symptom Management by my colleague, Dr. Erica Kay at St. Jude. And what we found is that the early integration of palliative care for children with cancer improved the symptom burden and management, improved in the perceived quality of life in meaningful events at the end of life, decreased hospital admissions, ICU stays, intubations, emergency department visits, etc., improved communication between the healthcare team and families, increased the likelihood of advanced care planning, improved caregiver and patient satisfaction with care, more likely to be enrolled in hospice and die in their preferred location, often in the home. And while this isn't the motivation for what we do, what we saw is that this also actually resulted in a reduction in costs to the healthcare system because we were being more efficient and effective in providing the care that these patients and families needed. Most importantly, early referral to palliative care did not result in earlier mortality, right? So we improve outcomes without resulting in earlier mortality. And in fact, in the adult literature, we actually see that for many patients, they actually live longer when they're enrolled in palliative care. So again, I asked that question, why is early integration for children with cancer so important? It's because our patients are suffering, and the early integration of palliative care can reduce and alleviate that suffering. One thing that I think is really important with this as well is I'm talking a lot about childhood cancer specifically because I'm a pediatric oncologist. But I want to emphasize that this isn't just for children with cancer, but really with any child with a life-limiting or a life-threatening or a catastrophic illness. You can incorporate these principles of high-quality palliative care into your practice. And so I really want to make sure to emphasize that. The rest of this talk will be talking about our experience with the integration in our team at St. Jude, but I hope to be able to incorporate this across the different spectrum of diagnoses where we know that these patients and children suffer. So one question that we also then get is, well, this is great. All right, palliative care, I know that it works, but our patients just aren't ready to talk with the palliative care team. It sends a bad message. We don't want them to lose hope. This is another paper published by one of my colleagues at St. Jude in the Journal of Clinical Oncology, and what they showed is that when you ask and when you tell patients and families and you give a proper definition of what is palliative care, overwhelmingly these patients and families want this. Of course we want an improvement in our quality of life. Of course we would love for a team to think about and dedicate themselves to thinking about how to improve our day, how to make sure that we're focused not just on the curative but also on the quality. And so really often when we hear, oh, our patients aren't ready for this, it's not the patients and families that aren't ready, it's the medical team. And so how can we support our colleagues in understanding this? And so when I use this word, what is an integrated approach to pediatric palliative care, we think about, and it's just more than just having a palliative care professional. It's not like, okay, we now have a palliative care specialist in our hospital, we've got a team, right? It requires so much more. So this is another example, and there's several examples in the literature of successful models of palliative care integration. And I think what's important is this, is that each hospital, each institution, each country, each region has different skill sets and how to integrate and incorporate some of these things into their own settings and practice. This is one that we use in this kind of tiered approach. And the first is this bottom tier. It's this idea that at an institutional level, everyone gets a foundation in that primary palliative care. So all of our staff at St. Jude get basic principle training in palliative care. We provide required communication training for our Hematology Oncology fellows. We provide institutional support for outpatient services. And we create evidence-based standards regarding pain management. So whether you're a nurse at our hospital, a social worker at our hospital, a physician, regardless of specialty, you're getting a foundation in primary palliative care so that every patient is exposed and worked with a healthcare professional with a foundation in these skills. Then we have specific population level triggers. This is a trigger based, and so certain patient populations that we know have high needs, that really experience a lot of suffering in their treatment. Those with high-risk brain tumors such as diffuse intrinsic pontine glioma, metastatic bony tumors like osteosarcoma, those that are in phase 1 trials. Those are all patients that automatically receive a palliative care consult. Not because we think that they're going to die soon, but rather because we know that they have a lot of needs, that they suffer, that they struggle, and that both from the treatment as well as their disease. And so how can we incorporate this from the very outset? And then providing end-of-life checklists, dedicated rooms and space for these patients and families, as well as embedded pediatric palliative care professionals for the different teams. So as mentioned, I am both a palliative care specialist and an oncologist. I work closely with our solid tumor patients. So all of the solid tumor patients, I'm a part of our tumor board to kind of think through how to be able to help incorporate palliative care principles into their treatment. An example of this as well from our team is that every single patient who gets a bone marrow transplant at St. Jude automatically gets a palliative care consult, Again, not because we don't think that the transplant will work, but rather because we know that transplant is hard, that the process of transplant is very, very difficult, and they have a lot of symptoms. It can be psychologically distressing to be in the transplant unit for months at a time. And so knowing that we provide this automatic consult to think through how to be able to support these patients and families through it. And then that top level is that, kind of getting those on-demand or consult-based interactions with patients and families based off of those situations in which there are complicated or refractory symptoms or challenges in communication, et cetera. There are several other examples that exist in the literature. This was published just a few years ago by Ana Lacerda from the team in Portugal, thinking about that primary palliative care provided by the team, thinking about that embedded expertise like what we have, but then also having some sort of integrated care model and regular touch points. And so there's a lot of different things in the literature that are there. I think I'm excited for Dr. Julie Ling's talk, because she'll also show the WHO conceptual model of palliative care and incorporating things into that and thinking about that at a national, regional, and global level. But there are a host of different models that are there. But again, I think what is important is just that recognition of how to incorporate these different things into your own setting and your own practice and build what works in your own culture. And most importantly, this didn't happen overnight. Right, this is something that takes time and that you build, and I've been so impressed visiting here in Tashkent to see the beautiful work that has been done by colleagues here to build pediatric palliative care here, and really thinking about how to get there. There's a couple of key principles. First and most importantly, it's that access to high quality palliative care is an ethical responsibility, right? This has been pointed out in the World Health Assembly resolution, and that this is something that we should and need to do. Second, helping our colleagues recognize that we're often the ones that aren't ready for this, and that patients and families are needing this and wanting this. And then thinking about how to make sure that this is sustainable and scalable. Thinking about, where do we start? Do we start in one unit or one team, and then how does that grow intentionally from there? And then what I think is really important is thinking through how we engage and understand the needs of and partner with our patients, the parents, and family members. Really learn about these things, and I'll talk about this. And the power of research, the power of data, learning from what we do, publishing our efforts, refining and repeating. And so for sake of time, I won't go into too much detail with these, but happy to share these slides with you after, because there's a lot of evidence in the literature about different research priorities in this space, and that the importance of how research and data can help guide the provision, funding, and evaluation of palliative, end-of-life, and bereavement care for children and families. This was published in 2003, and seeing that the recommendations regarding the areas of focus for the research haven't changed much in over 20 years. This was published about 10 years ago by Dr. Baker, one of my mentors who's now at Stanford, again thinking about these themes of decision-making, care coordination and access, symptom management, quality improvement, and education. This was published by Dr. Julia Downing also about 10 years ago, looking at this global group and thinking through what are the needs, again, understanding the needs that exist in these different spaces. This was published in about 6 or 7 years ago by another group. And so, again, not to belabor this point, but there's a lot of emphasis in understanding what our needs are and having a foundation in research and high quality palliative care for children, and how that can help guide our initiatives moving forward. And I think it's so important thinking about how we engage with those with lived experience with this. This is Blythe Lord is the director of the Courageous Parents Network, a group of advocacy group in the United States that talked about the importance of what are the parent perspectives regarding palliative care research and the needs that they have for their own support and the opportunity that they have to participate in this research, not just as subjects, but also as co-investigators. And that was a huge turning point for us at St. Jude. We had a lot of interest and emphasis in palliative care for many years and didn't really get much movement in the improvement of our palliative care services until we had a group of bereaved parents who came together to write a series of things that they were hoping for and that they needed. And then they took this list to our CEO of our hospital to say, hey, we see all of these beautiful pictures of children being cured of their disease. We see all of these incredible signs and ask for donations to our hospital. But what about our children? What about our family? How can we share our story and show what we need? And that changed the paradigm. That changed the efforts of our hospital, where our CEO heard from these parents and then started building supportive systems for patients and families, thinking about how to incorporate palliative care earlier into treatment, how to think more effectively about how to provide high quality end-of-life care in the hospital as well as closer to home, how to then provide robust grief and bereavement support programs for patients' families after the death of a child to help ensure that they get the support that they need to reintegrate back into society. And this isn't something that just happens at St. Jude. This happens around the world. This is an example of some of our colleagues from Colombia who built an incredibly beautiful palliative care program. This has been replicated in Kenya, in Pakistan, in India, here in Uzbekistan. Around the world, there are phenomenal palliative care professionals who are working closely as an interprofessional team, hand in hand with patients and families to better understand what they need to be able to incorporate these principles into their practice. So as I close, and I'm very excited to hear from Dr. Julie Ling and thinking about this from a policy perspective and from a national perspective and how to incorporate this into what we do, there was a paper published by one of my mentors, Stefan Friedrichsdorf, about the stages of palliative care development. And the first stage is denial, right? This idea that there's no institutional awareness of the need. This isn't something that we should be focusing on. The next stage is something that he calls palliaphobia. And it's this idea of, we're starting to recognize that we need palliative care, but we're really nervous and afraid of how to move forward with this. The third is pallialia. And this is this idea that you recognize the need and the importance, and you're starting to get some resources, but you're still under-resourced. And so you're still struggling to meet the needs of the patients and the family. The last one is palliative. And this is where you're finally getting the recognition of the need, you're starting to understand this, and you've fully embraced, staffed, and resourced as an institution. But I want to add one more, and I think this is where we are, and I hope to be, here in Uzbekistan and around the world, is really thinking about how can we be pallia pioneers, right? How can we not just think through and be fully staffed, but really redefine the field of palliative care? What is the standard of care in that early integration? And how can we use high quality research, high quality evidence-based approaches in collaboration with our partners as an interprofessional team along and work hand in hand with our patients and families to be able to ensure that every child everywhere, regardless of diagnosis or prognosis, get access to the care that they need and the care that they deserve. So thank you so much for taking the time to listen to me today, and I'm excited to continue to have these conversations with you over the next couple of days.
Thank you very much, Dr. McNeil. And by your permission, we leave the Q&A session for later when we have another 2 more lectures. And then in the discussion forum, we'll talk about it. Thank you very much. And the next, I would like to invite Dr. Julie Ling.
It's great to be here. It's my 4th time here in Tashkent, so I'm very happy to be here again. And it's good to see so many of you early in the morning. I was just thinking about what drew me to palliative care, and I actually think that it's not a specialty that everyone thinks when they start their training in healthcare, I'm going to be working in palliative care. But we all die, and dying well is a human right, but actually many of us don't die well, so I think it's in all of our interests that we actually work in palliative care and that we really buy into this and learn and educate ourselves about palliative care. Because a good death is not always available, and in fact in the European region around 70% of people die in hospital and not at home, which is where most people would like to be if they were given an option. I work in the European office of the WHO, And that represents 53 countries, from Portugal in the west right the way across to the far reaches of Russia in the east, and everything in between. And I guess all of you will know that there's huge diversity in that region, culturally and in every other way. And in fact, sometimes when I'm here in Uzbekistan, I say in the European region, and people say, but we're not in Europe, because I don't think that's, people don't perhaps view this region as part of Europe, but for WHO perspective, it is. And I think we can see that quite a lot of what we've learned in other parts of the region can be applied here in this part too. I'm coming back to that. So just like Mike, I'm going to start with the World Health Assembly resolution. And for those of you who are feeling tired, I'm sure the thought of something like this would probably make you feel even more tired, because we often think as healthcare professionals that policy is not really anything to do with us. But actually policy influences everything we do, and it's a topic that in healthcare we often think is made by someone else, but actually it impacts on the care that is delivered to the people that we care for. So the World Health Assembly is the decision-making body of the WHO. So they meet every year in Geneva and they decide on what topics they're going to implement, and countries sign up to it. So in 2014, this was a landmark resolution, and it was the first time palliative care had been mentioned, and this resolution was passed by all of the countries. And it talked about strengthening palliative care as part of primary care, across the life course. So this was really important. So all of you working here with children, this was the first time that it was from neonatal and pre-neonatal care right the way through to old age. So this is about everybody needing palliative care. So it really has been a very, very strong force for change. It's now 16 years since this resolution, and actually there's been a few reviews, one by the Wish Foundation in Qatar, and others across many range of researchers have looked at how this resolution has made a difference. And sadly, it hasn't made as much of an impact as we'd like, but maybe this is just the beginning and we can perhaps work on that. So I start most of my talks with this, and this is really basic. So if I ask different people in different countries, and I'm working with other countries, so I work with Uzbekistan, Tajikistan, I've been working in Russia, in Greece, in Moldova, and more latterly in Romania. And if I ask, what do you think palliative care is? People have different ideas. They don't really know. So I always think by showing this slide, we can all start at the same place. This is what we're talking about. We're talking about special care that tries to improve quality of life. It's not just for people with cancer. This is a common myth and a misconception. And I think this is built from the fact that palliative care actually originally started for people with cancer, but it's spread, and in other countries across the world now, palliative care is available to people with life-limiting and life-threatening conditions, regardless of that cause. And perhaps in pediatrics, even more so, because in many countries, the majority of children who die do not die from cancer because we have, better treatments. So I think we need to think about all people with life-limiting and life-threatening conditions. And that can be hard for healthcare systems because, actually deciding who is available, who should have palliative care and where it should be available can be really difficult. It improves quality of life. There's so much evidence, and Mike presented some of that, around it improving quality of life. And these are things that are easily measured, but this means we have to ask the patients and their families, did this improve your quality of life? We need good research, solid evidence. We need to make sure we include the patient and their family in all decision making. And culturally, that's not always the case. Some people, good morning, and some people actually, and in some cases, we use patient-reported outcomes. So we actually ask the patients and we measure, does palliative care, are we improving what we're doing? Mike mentioned it relieving pain, physical, psychosocial and spiritual suffering. But that's quite hard to do. And if you're only one doctor working with patients in palliative care and you don't have a team around you, it's really difficult for one person to meet all those needs. You sometimes need a team. And also those people need to know what palliative care is and be on that journey with you. it benefits healthcare systems, so there's evidence that it saves money. That's always a good thing for governments and ministries of health to hear. So there's really strong evidence of the economic benefits, that it means that patients get less futile treatments. Perhaps things are not working, chemotherapy is stopped, or invasive tests and examinations are not undertaken. And because most of us, if asked, would say we would like to die at home. And quite often what happens is people are sent into hospital for more treatment or for more tests, and are not dying where they want to be. And as I say, between 50 and 70% of people dying in hospitals. And the impact that has financially on the healthcare systems is huge. So having to look at a different way of providing that care is really important. And that brings me to the next point, that palliative care, and people sometimes use hospice and palliative care interchangeably, but actually hospice care, hospice care is part of palliative care, but not everybody who needs palliative care goes to a hospice. So we need to look at that terminology, and it's different in different countries. Mike and I were talking about this. In America, what a hospice is and what hospice care is different to what we see in a lot of European countries, and it's really system dependent. So again, it's about that model. But when you ask patients, most would say they would like to die at home. It's not possible for everybody, but for many it is. But we're not managing to meet that because we don't have the services in the community, or we don't have the healthcare workforce to manage that, or with the right training and experience. And as healthcare professionals, we can be really scared if you've got somebody at home and you want to care for them. And for example, I know maybe strong opioids, we'll go back to that topic, but people are scared of prescribing, or they don't see many people who have a end of life and need pain management, and so it can be very scary as clinicians to do that if you're not used to it, or you don't have the education and training. So this is really important. So palliative care should be provided by a range of healthcare professionals. It doesn't have to be a doctor leading the team. In many countries, nurses have developed home care teams and other professionals, and even we include volunteers in this. So in, for example, Western Europe, you would have a whole team of people who would be involved. So you would have physiotherapy, occupational therapy, and then we train up volunteers. Sometimes these are people, family members of someone who's died, who want to give back. They have specific training and go into people's homes and help, or drive people to appointments and so on. So you can really make this a community thing, so that people are involved in palliative care. And I think in some countries, death has been removed from our healthcare systems. We want to cure everybody, but that isn't the case. And in society, we don't talk about this, and talking about what a good death looks like and that dying process. And certainly in many Western European countries, people would go into hospital and die there. And many young people have never seen anybody who has died. And that's a big change over the last 100 years. So there's this whole cultural thing about death and dying, and it being removed from our societies. So this is the WHO conceptual model for palliative care. So what does that mean? It means that this is all of the elements that you need if you want to build a strong, sustainable palliative care service, or in your country. So this can be built, you can use this at a national, a local, a regional level, and we certainly look at this in the WHO. So this model was developed by people from across the globe who work in palliative care as the key elements of what we need to provide. So if I put my little house model here, I don't think there's a pointer, but so our foundations, what do you need to build a strong palliative care service? You need to empower people and communities. This is death literacy, talking about death and dying, not taking it away from the community, actually addressing what people want, advanced care planning, what would you like, involving people in their decisions, and talking about death and dying. And that can be quite hard because we all want to stay young, we all want to live forever, and we talk about curing people, but we can't cure everybody, and you all know that as healthcare professionals. So it's about having those conversations and starting those conversations. Health policy, so that's the bit that's not always so exciting, but it's really important. So if you don't include palliative care in your national policies, and you don't have a national policy for palliative care, then governments don't fund that service, and so you really need to make sure that it's included at every level. And this is not just having a standalone palliative care policy that's in a hospice or in a palliative care unit or in a cancer hospital. You need to include palliative care in your policies for older people, for primary care, for cardiology and other diseases that we know people will need palliative care for. Mike spoke about research, but again, there is so much research in palliative care now, but you need to do your own. So here in Uzbekistan, you have a unique culture, and you're in a unique country, and you need to not take everything from other countries and say it's going to work here in Uzbekistan, because that's not what happens. So as clinicians, you need to think about what are the things that are bothering your patients and the families. What is it that you need to measure and look at? You need good data. You need to know, where do people die? Where do they want to die? Are they getting good quality of care? What are they dying from? So you need to have this data, and you need to undertake research and think about that. And of course, as clinicians who are busy and working here, you need support. So this has to be as part of your education, your academic system. So you need to have opportunities to undertake that with supervision from professors in palliative medicine and so on. And of course, this is the goal in the future. And that brings me to the pillar here, which is about education and training. This is the key. If you haven't had education and training and you don't know what palliative care is or how to provide it, then that's a big issue. We need, the biggest part of all of this is workforce. It's not a hospice or a building. It's about developing people and our skilled workforce to enable them to provide palliative care. And that's the key to probably the whole of this, and the most important thing here. I'm going to move across to the use of essential medicines. So there is a list of essential medicines from the World Health Organization that is updated every 2 years. There's a specific list for adults, and there's a specific list for children, and these medicines should be available. And this is how you're going to manage the physical symptoms for children and for adults. And this includes, and it's not just about access to opioids, but this seems to be the part that really is the most difficult and challenging for many countries, and for many reasons. And I guess maybe working on the post-Soviet model, you had the same system that Russia had in the past, where you're looking at, restrictions on prescribing and on dosage and on formulations, and that can be really challenging to address. And I'm going to talk more about that. But the roof of our house, so this model, is that we integrate palliative care into all healthcare. And we can do this at many levels, so you don't have to be a specialist to use the principles of palliative care. And in fact, this should be like basic palliative care can be done by everybody and should be taught in undergraduate curricula for doctors, for nurses, and all healthcare professionals. And then you can go on and train further, but we talk about that. But in palliative care, patient and their family are at the heart of everything. We include them in the conversations, and we make sure that it's their wishes that we're looking at and seeing how we can help them to have the best possible journey, and I think that's really important. So these are the really important building blocks of palliative care. And I've got my arrows, just in case you didn't see. Okay, so the European Association for Palliative Care, in conjunction with a World Health Organization collaborating centre, has collected data, and this is just the European one, and you're in the European region, but there are the same documents for the whole globe at this point, for Africa, for Asia, Pacific, and other areas. So this atlas was published last year, and it's the 4th one in a line, so actually it's very good if you ever want to look back at the history of how far we've come. And this atlas contains data on all 53 countries in our region, so including Uzbekistan. So this is the data for you. So I was looking last night and thinking about what's measured. So what is measured in this, and how this mapping is put together, is they look at the house model, and little parts of it are broken up. So it's about essential medicines, it's about education and training, it's about national policy, it's about the workforce, about integration of care. And I can see that Uzbekistan is at the very early stages of development for palliative care. But this is only now, and I think in another 4 years they'll do this again, and we'll have moved on a lot further here in Uzbekistan, and that is the goal. And I know from people here that you really are embracing the whole idea of palliative care and making sure that this is something that's prioritised. you can see, I'm sorry, you probably need really good glasses to see this, but very, very low opioid consumption. And this is reported to the International Narcotics Control Board. So very low consumption of opioids here in Uzbekistan. And that's an indicator that perhaps people are dying with unresolved symptoms and that we need to look at how we can improve that. And that could be around changing regulations, legislation, improving education and training of the workforce so that they feel more comfortable to prescribe. As part of my work here with the WHO, we undertook a situational analysis and a needs assessment of palliative care with colleagues, Dr. Rustam, Dr. Yahyo, who you'd know, who helped to collect data on all aspects of palliative care here in Uzbekistan. And I can just give you some of the things that we found that we need. We were looking, so again, it was the same things you saw in the mapping. But what we really need to look at is integrating palliative care into the health services and international policy. Need to develop palliative care in the community. And this is quite difficult because you need to have people who are educated and trained. So we need to train people first so they know how to provide that care. Because providing care in people's homes can be even more scary than providing care in hospitals where you have colleagues to help. So we need to make sure we have really highly skilled and qualified teams that can go into the community and provide care. And we need to provide a network of support to them so that they're able to deliver really good palliative care. We need to have education and training. In the last 2 years, we've conducted 3 Train the Trainer programs here in Uzbekistan. One was for pediatric palliative care, one for nurses, which was really well attended, and also one for general palliative care. We had our colleagues from Sessionov University in Russia who came and provided that course and that education and training. But we need more than this. We need to support, and we need to have a network and a community of education and learning, and we need to be able to support the people who want to work in palliative care. We need to look at changes to legislation for access to essential medicines, because I think that's a factor, a barrier at the moment. We need to recognise palliative care as a specialty, and that's really important because not only is it one of the indicators for development of palliative care, but it's also around making sure that we have this structure that supports the development of palliative care here in Uzbekistan. Development of paediatric palliative care as a separate entity, because there are some similarities, but there's also a lot of differences. And ideally, and in a perfect world, paediatric palliative care is provided by paediatricians and by people who are trained to care for children. And obviously, in some countries, that's not always possible, and there is some overlap with adult services. But if we're looking for the perfect, that's the model, that you actually become a specialist in paediatric palliative care, and that's a possibility. We need to improve death literacy, so people need to talk about death and dying. They need to express their wishes, where would they like to die, looking at advanced care planning. If I were to die, what would I like, where would I like to be, and so on. And then there is this need for data, which I already mentioned. There's a lot of WHO publications that can help you in development of services. And if you're at the very basic level, there is one on planning and implementing palliative care, and right the way through. So primary care, obviously, if you're going to care for people at home, you need to have that infrastructure in place, whether it be through polyclinics, regional and district oncologists, or whatever way that will be. And then also there's this really useful document on integrating palliative care into pediatrics. So these are some really good documents that look at essential medicines. So this is the document I spoke to you about, which is the essential medicines list. So I think it's chapter 2 and 3 are on palliative care, one for children, one for adults. There is a new document called the WHO Guidelines on Balanced National Control Medicines, and this is for policymakers to tell them this is what you need to do to enable your healthcare workforce to safely prescribe strong opioids for medical use. And then same again for children. And then this document that we were speaking about yesterday, Left Behind in Pain, is also reporting on the number of countries and places where people are actually unable to access the medications they need. And we know these are really safe and effective if they're used well, but it's just having the experience, the confidence, and the education and training to be able to administer these drugs. So what do we want? We want to have palliative care integrated into health systems as part of universal health coverage. That's a real WHO term, universal health coverage, so should be available to people free of charge where possible and be integrated into your healthcare system. So palliative care should be a core component of universal health coverage. We need adequate funding and support. And the other issue around funding that I should mention as well is in many countries the influence of, for example, the pharma industry. So there's this commercial aspect to it. So perhaps where we know that immediate release morphine is the drug of choice, which is recommended, that people are buying really expensive drugs, fentanyl patches and so on, which are a part of your armory but shouldn't be your first go-to. So that's the commercial determinants of health that we need to think about as well. So that's for your procuring of drugs, supply of drugs. Also, if you want to send people home, the local pharmacy has to be able to stock and supply the medications people need so that they don't have to travel back long distances to collect medication. We need to make the process smooth and as easy as we possibly can. And we also want to make sure that palliative care is informed and shaped by communities. Mike mentioned families being involved and giving their views. And in many countries, there would be patient associations and perhaps relatives, friends, even patients themselves who belong to different associations and who are often now at the table when we're developing policy, which is hearing the patient's voice is really important. So we have collaborating centres, and these are just some of them: Session-Off University, Dame Cicely Saunders Institute in London, the University of Navarra, St Jude. I'm going to show that picture again in a moment and explain why. We have across the globe different collaborating centres. So what's a collaborating centre for the WHO? They undertake work on our behalf and with agreed objectives, and we've become a very good community and able to support the development of palliative care, strengthening it across the globe, learning from each other, because wherever you are in your development, we've all been there and we can learn from each other. Regardless of culture and country, there's so much we can learn from each other. So this group started small, so that this is our WHO palliative care group, and started very small, then we moved to a big one, and then last time we were even bigger again, with a really, really defined work programme. And one of those programmes is looking at helping to support individual countries to develop, and at the moment one of the countries we're looking at for paediatric support is here in Uzbekistan, but we need to put that forward. And what does that mean? It means we need someone from the country to be involved, you need national leads, and then this group, who are global experts on palliative care, will provide webinar support and support to help develop palliative care in your country. And I think it's in the initial phases, we're only looking for nominations at this point, but I think this is a really exciting project that we can move forward and will have really tangible outputs. So if you want palliative care, and then I'm going to stop soon, hold on, I'm okay. So I think what you need is political will. So you need your government, your ministry, you need your management and higher levels to be able to support palliative care. You need local pioneers, and you need people who really understand what palliative care is and what it means in your country. We can take models from other countries, they don't always fit, but we can take the best parts of those and bring them. Here, I would say Dr. Yahyo and Dr. Ustam, Kilola, that people here who are really supportive, and Dr. Jamila, who's really in that leading role and supporting palliative care, which is great to see. We need to look at funding and how that can be, because there will be initial investment, but there'll also be big rewards. And palliative care is not high cost, but it is very high impact, and that's what we have to remember. And it can, the way somebody spends their last years, months, days and weeks can actually impact on the way we think about death and dying forever. And so we really need to get this right and make sure that we try and get that right for every child, every adult. We need to build on links and our collaborations and make sure that we actually use those really effectively. So here in Central Asia, I don't speak Russian, I'm sorry. I don't speak Uzbek either. But I think what we really need to think about is how we can link you with people who have a similar system, because you can go to the UK and look at a hospice and look at it, how it fits into the infrastructure there. But can you bring that back here to Uzbekistan? Maybe, maybe not. But maybe somewhere like Russia, where they've been through this process, you can really learn from them. They've changed their laws and regulations, so they have access to many formulations of strong opioids. They have developed hospice, hospital-based teams, community teams. So there's so much we can learn from each other. So the barriers, limited understanding of what palliative care is at many levels. I hope this morning, even if you take one thing away, you know what palliative care is, what it should look like, and what components there are. We have limited data, so we need more of that. Cultural and social barriers, so we have to think about those in the context of your country, your culture, and we have to be sensitive to those, because not everybody, I know you have I went to Samarkand Hospice to visit last time I was here, and in the hospice I asked them how many people die in the hospice, and they said people don't die in the hospice, which to me, coming from Western Europe, was really unusual. But of course, culturally, people here want to go home. But what you want to go home to is a home environment where you're supported, and that you're having your symptoms still managed and cared, and you're being cared for, and that your family are being supported. So even just sending someone home isn't always the answer. Restrictive legislation, which we know about and we've mentioned, limited funding and investment. We need to look at ways of perhaps supporting that. We want to dispel the myth that palliative care is for cancer only. It's for anyone with a life-limiting or a life-threatening condition. And then the lack for healthcare professionals, we need to help them get that experience. So what would that look like? We need to look at training programs, support, clinical placements and other things to ensure that people understand what palliative care truly is and what it looks like, because when you haven't seen it, then you maybe don't know what that looks like. So I'm going to leave that one because that was some questions. But I just want to finish on this saying that Uzbekistan, I have to say, I've been here now 4 times, and I can see already this commitment, and even by your Ministry of Health and your Department of Social Protection, things are moving forward. And I think by the time we get to the next atlas in 4 years' time and we're mapping, I'm going to see very different data for that. And I hope many of you have the opportunity to learn about palliative care and get that interest that Mike spoke about. We need pediatric oncologists, but we need pediatric palliative care doctors too. And I think maybe there's one here this morning, and hopefully they could be the next pediatric palliative care pioneer as well. So thank you very much. Thank you.
Мы благодарим Джулию Линк и приглашаем.
Thank you very much, Julie Ling. We'd like to invite the director of the center, Doctor of the Medical Science, Garad Platino. Good day, everyone. Good day, everyone. I'm very glad to see you here and welcome you here. And I would like to also be happy for you to be present and witness this kind of situation when these kind of high-profile figures who dedicated their lives to protect, to develop the palliative care when the condition, unfortunately, it is the uncured disease on that stage when the patients need help, not only in children but in other directions. The perfect special Julie Ling. I'm honored to meet and befriend these guys, and now that kind of expert and the person. Thank you very much, Julie Ling. And I'm also privileged to meet Mike. Welcome to Uzbekistan, Mike. First time I meet that kind of specialist who dedicated his life to a very difficult direction in medicine, but the ambition and the strive to improve the condition of the children, in particular we're talking about children. In fact, it shows the high profile and motivation that we also have to think about the other way of the patient. Unfortunately, that path from the first day of the disease, it starts when we have to support comprehensively from social, from psychological, to patients and their parents, their closest. In our mindset of Uzbekistan, it's good when a child is not alone and the mother is not alone, when we have an extended family, and we all have to support them when they're in the bereaved. This is our mindset when we talk not only with patients, that all could be understood and explained, that the patient has a backup team who can altogether support. Thank you very much. And now we have time of development, very speedy development. The system of child cancer is developing different directions, and the Uzbek government also has highlighted the palliative care not only for children but throughout the country. The system, when we have the malignant cancer, that this is maybe only 3-5%. If I'm not wrong, if Julie can correct me, these patients, the cohort of that patient, but the predominant part, of course, is directed to other diseases. And I'm very honored to be at the beginning of that. And I'm very happy for you, because we can see the development, not only the system of the children against the cancer, but the services like the support palliative care, of course. And we are at the spring, at the beginning of the birth of the palliative care in Uzbekistan to children, adults, not only in cancer disease, but in the whole healthcare system. And now we can see that they're planning the bill, which will be signed by the Uzbekistan to start the palliative care in Uzbekistan. And I call you all, doctors
and all those stakeholders, that to come to and help our children. We all should unite efforts and work hard. So I mean here the pediatricians and social support staff, psychologists, everyone should be thinking of how we could further support our patients. Yes, the patient is ill, our infant patient is ill, but we have around family, parents, us. So when we are together, we are strong. And I would like to wish you all the best. I would like to thank our experts for their contribution, for their time to be here. Thank you very much. Thank you very much, Ravila Shagaratovna. Dear colleagues, let's now move to the Q&A session. Yes, please.
Thank you very much for this meeting to organize that kind of masterclass. I believe our workers are all inspired, and in future will work in upscaling the level of palliative care. My question: in our country, we have seen the restructuring, and we don't have the specialty, the doctor of palliative care. How this issue is resolved in England and the US? Do you have a specialty in the healthcare system, or we have only the pediatric oncologist has all the burdens? Next question: how are you collecting data? How many patients need palliative care in terms of oncology? Because that question structures our planning. Maybe you can help and advise how to take the path, how to collect the exact data.
Specialty. Okay, so I can speak for many of the countries across the European region about training as a specialty in palliative care. In some countries, palliative care is a subspecialty, and in others it is a distinct specialty in its own right. So you mentioned the UK. In the UK, since 1995, you can be a specialist in palliative care. But palliative care education and training is the key. So often it's often described in 3 levels. So you have a palliative approach. So this is for everybody who is training as a healthcare professional, regardless doctor, nurse, everybody should have a palliative care approach described to them in their undergraduate training. So you should have some idea, so you know what palliative care is and you know how to provide basic palliative care. And in many cases, we might describe that as just really good patient-focused care and listening to your patient and actually addressing the issues that they raise. The next level is generalist palliative care, where you may have undertaken a short course or some training, and then that is that you are not a specialist, but you can deliver palliative care and you have a higher level of knowledge about what palliative care is. And then the third level is you're a specialist. So in many, not just in Western Europe, but in some of the Eastern European countries like Romania, you can do specialist training as a doctor. You can, the length of that course, it'd be like training as an oncologist, so maybe 2-3 years, sometimes 4 years as working with a consultant in palliative medicine, and you then have this training program and you move through different services, so it could be a hospital, a hospice, and you would develop your skills, and then you are then certified by your state board or your national board, and that just depends on what country you're in. So then you are a specialist in palliative care, but being recognized from the other way is about your regulations here in your country. So that would depend on, you know, how your national body would recognize those qualifications. And so you would have to develop that kind of program. And that's really important. That's part of the education and training pillar of the public health model, is that you have the ability to train and be a specialist in palliative care. So I can say that in some Western European countries it's possible, and in others they have different. So it's, again, it depends on your country, but it's something that you should think about. And certainly then you could have academic departments of palliative care and palliative medicine, professor posts. That happens in many countries. I told you I'm working in Romania. They have 4 professors of palliative medicine. In nursing, you also can specialize in many countries, and this is an additional skill. And in many countries in the western part of Europe, we have problems with recruiting and retaining nursing staff. They often move for different jobs for more money, but actually enabling them to have the ability to train and specialize in a particular area like palliative care often helps with this. People don't want to leave, and when you have a different qualification, then you often get paid more, and so there's other things, incentives to stay. And again, we even have specialists in physio and other things. So it's really about your country and what your level of commitment is. And I won't answer the question about cancer. I'll pass that to Mark.
Yeah, so going back to the education piece again, the model in the United States is different than the model in the UK. And so, you know, for my training to become a palliative care specialist, I did an additional 1 year of training on top of my pediatric oncology training. It's a formal fellowship in palliative care. It was a 1-year training. But what's interesting is there's no specific subspecialty for pediatric palliative care. It was all hospice and palliative medicine. So I had to go to our Veteran Affairs Hospital and take care of adults for the first time in 10 years. And that was a little daunting because I hadn't taken care of adults for a while because I'd gone into my pediatrics training and then my pediatric oncology. But technically, I'm board certified for both adults and pediatrics, but I only take care of pediatric patients. And so each model is a little bit different, and so working and better understanding what that, but I completely agree that having a specialty in palliative care at a national level is really important and valuable to really demonstrate its emphasis as a unique specialty with unique needs and unique skill sets, and how to be able to incorporate that in. into that. And then, we're continuing to work at a national level and global level to emphasize, as Julie so eloquently mentioned earlier, the unique nature of pediatric palliative care and the fact that children are not just little adults and that their needs are quite unique. With regards to your second question, I think it's so essential. Data is just so powerful. And so what we have been lucky enough at our institution that we have been able to work with our electronic medical record to incorporate palliative care consults, visits, diagnoses, and needs into some of the data that we gather with our electronic medical record. So each year we know how many consults we did, how many patient visits we did, what were the most common diagnoses that we took care of, what were the needs that we took care of, how many patient family conferences, things along those lines that were really important for us to be able to go back to administration to show, look at what we're doing, and how each year it has continued to grow as we've been able to better integrate into the hospital, better develop those relationships with our collaborators. And so I cannot overstate enough the power that data has in conjunction with the narrative and with the stories that we have of working with patients and families. And so certainly, there's different systems and processes, and happy to kind of chat through what are different types of data to collect, and what we've seen to be most successful at a hospital level, but then also thinking about that at a national level and even at a regional level. I think the Atlas is such a great example of that, of different type of indicators that exist, and the WHO has come out with indicators to keep track of palliative care development. As far as which patients should get palliative care and which patients shouldn't, right? That's always that big question, the overarching philosophical question. And so like I said in my talk, I think every patient should get palliative care. And not every patient needs to see the palliative care specialty team, right? And so all of us are palliative care, we all are palliative care providers. We can all relieve suffering. And thinking about who should get that consult with our palliative care specialists, there are some good tools in the literature for that. There's a couple of scales that you can use. One's called PAPAS that you can actually use to be able to see, all right, are they having refractory pain? Are they having refractory this? That you can kind of use, and happy to share that. These are validated tools in the literature. At the end of the day, though, I think the easiest answer is if you think that palliative care should be consulted, they should probably be consulted. Right, and if that even comes up as an idea, it's probably best to kind of bring them in. If you're, but there's definitely some tools available to help, identify who are those patients most in need.
Спасибо большое.
Thank you very much.
Про Захида.
Yes. Good afternoon. Thank you very much for a wonderful lecture. I welcome you all. So I am very happy to see you again in Tashkent, our colleagues from Think Global and WHO. So my questions are following. If we conduct the training on palliative care, so this training, let's say we have this specialist on palliative approach. So that should be, does it mean that it will be just the hematology specialist or the specialist that can support everyone? So we speak about now children. It can be neurological or other organ illnesses, for example, primary immunodeficit, and or it's a training that we had, that you had, for example, during 1 year after your general study. So this is the first question. And the second question, what system, of the modern palliative support would you recommend? It's just the branch in the clinic, or it's hospice, or it's the team that comes to your home? I think that they can all be included, but what should be the percentage? What should be the percentage of hospices or the teams coming home, etc. And the third one, in accordance to standards, European or American, what is the workload for one nurse and the doctor of palliative support? How many patients should come to each?
All super important questions, and I think we'll try and tackle a couple and share between the two of us that. So the first question with regards to, is this just for children with hematologic or oncologic conditions? And I think the big thing is it absolutely can and should be offered to patients outside of just that patient population. We know that globally, I'm a pediatric oncologist, and so that's what my emphasis is. But we know that around the world, the children who have palliative care needs go well beyond just those with cancer or other hematologic conditions, as you alluded to, neurodegenerative conditions, cardiac conditions, complications associated with prematurity, cerebral palsy. These children suffer, and the integration of palliative care into their management can be incredibly effective and important in helping support these children. And so I would say that often palliative care is started in oncology, and I think that there is a huge opportunity to be able to spread that beyond just those patients to pediatric patients more generally, and to be able to think of some of those other unique patient populations that do suffer and how to be able to incorporate that in. So I would say yes, it is definitely something that can and should be offered to these other patient populations. Second, with regards to, I'm trying to remember the two. The second question. The structure. Yes, that's right. As far as, again, I think it is really contingent on the system in which you work. And so, for example, where we are, we have an inpatient team that does all of the consults in the hospital. We also have an outpatient service, as well as a home-based care team. But we do not have we don't have a hospice. And that's just with the system in which we work. Our patients, when they come to St. Jude, are often coming from other parts of the world or from other parts of the United States. And so, they either want to stay there, or if they do want to return home for end-of-life care, they're at another place. And so we don't need a physical hospice space. But there are other places that do have a physical hospice, because that's what those patients want and need, to be closer to home, but not quite in the home if the opportunity and availability for a home-based care team is not possible. And so I think it really is contingent and dependent on the system, the healthcare system in which you work, as well as the resources that are available. And most importantly, that it grows over time, right? As I mentioned, the program that we have at St. Jude, it didn't go from one day to the next into this large program that it is today. It started with one physician and one nurse who were interested in palliative care. And they were able to go do some additional training to be able to get that. And then they came back and they carved out just a little bit of their time to start seeing some patients and getting that data to then be able to come back to the administration and say, look at how valuable this is to our patients and their families. And so then they got more protected time. And we're able to show, hey, with more protected time, look at how much more we can do. Now, if we had a social worker, how much more could we do? And slowly over time, it has grown into what it is today, because they were able to leverage the patient stories plus the data to be able to build that system. And we're still growing, we're still learning, we're still trying to figure out what works best for our patients and families, and getting that feedback from them has been so essential to be able to better understand how to support them. And so my thought with this is that really the best system depends on, one, your system and what the patients and families want and need, and how do you then come together to build that out. And then the third question, as far as the patient load, that's a great question, and I think it's really tough to answer, just with regards to that. I mean, we have, at our institution, we have about 350 to 400 new consults a year for our palliative care team, and we have close to 5,000 patient encounters. So that is a large volume for just kind of the team that we have, and so we've tried to divide that amongst each of the team. And so we can look at some of the literature and kind of better understand what those standards are. I don't know if the WHO has really published some of that, so I'll pass it off to you.
Thank you. I just was going back to your second question, which was about the model of care. So, again, it is always dependent on your system and what you have available. But there's this hub and spoke model. So you have this hub, and then services that go from there. So, if you are working in an oncology centre, then the chances are you're going to be the hub. And then you need to work what services are needed. But you're probably seeing people from the far reaches, so for Ghana, Samarkand, Bukhara, you're seeing patients from everywhere and you're sending them back. So where do they go back for their care? But so you need to have access to a network of support for the family. And it's, as Mike says, it's not just acute care in a hospital. So you can have hospital palliative care, hospices, home care, you can have respite care, you can have outpatients, and you need to make this as simple as possible, because we know with a really sick child, travelling backwards and forwards to different places can be difficult. So we need to make sure that services are available as close to the child and the family as possible. When you're talking about children who do not have cancer, so children with non-malignant conditions, and many, many palliative care services in other countries would care for children with non-malignant conditions too. They have a very unpredictable disease trajectory. So they can live for many months, years in many cases, many years, and need care over that time. So what they need, as opposed to what perhaps a child with cancer needs, is different. So for pediatric palliative care, it can be very difficult to work out. But you need to have your focal point, and that's what you need in your service. You need to have the hub, and then they can say, we need to send you back to the hospital, we need to send you for respite because your family can't manage anymore, we need to send you to see the dietitian because you're not able to swallow. So there's so many ways of doing it, but you need someone who is responsible for that child and family and that can navigate the services for them, I think. And that's sort of a model that works in many countries. When you talk about nursing and medical caseloads, it's a really contentious issue because nobody wants to give you, for this one doctor, you see this many, because it's different in every country. But last week, I was at the launch of a document from the WHO Nursing and Midwifery Unit where they didn't give you exact numbers of how many patients a nurse should care for, but they gave case studies from different countries and many different countries about how they measure that. So that's a document that I can share a link with. But I think the answer is that as physicians and nurses, you probably, some weeks you might see many more patients than others not. So it's about also looking at the quality of the patient care, ask them what kind of care they got. So include patient-reported outcome measures in your care. You also need to look at your team and burnout. Are you seeing too many? If you're a doctor working on your own in palliative care, then you're far more likely to feel overwhelmed than you are if you work as part of a multidisciplinary team who can help pick up some of the work. You don't have to do everything yourself then, so I think that's an important issue. And I'm sorry I don't have exact numbers, but that's a real WHO answer. That's, you need to look at other countries and look at those models.
Спасибо большое, Глеб Олегович.
Thank you very much for a wonderful report, the presentations. I wanted to ask the question related to the medical technology. So you spoke about the palliative approach related with the help of medical technologies as well. And if we look at the countries of Central Asia or European or Asian or the countries with low economy, or for example, you spoke about transformation in Romania. In my experience, indeed, the palliative support in its technology is different in other countries, let's say in US or post-communist countries. So we often can hear some social positions that palliative support is just distribution of drugs or some stopping providing some medical aid, but it's kind of some social technology. There is nothing medical here. And And also I heard the same things from Uzbek people working, officials. And there is nothing medical in the palliative support. And in this regard, wanted to ask, is it so when we speak about with our officials, what medical technologies could be on our way to civilize the palliative support, so that the patients in developing countries, and including those of post-Soviet, post-communistic, they could move to the standards of European countries. So this is a question: what medical technologies, except for
Б,
palliation, so could be applied, so the officials could understand that it's a integrative approach, not just segregation of patients.
I understand that. I think what Mike showed the slide where palliative care is involved from early on in a disease trajectory. So palliative care doesn't mean that you can't have any other curative or medical treatment. And in this context, you should and could have palliative care introduced at the time of diagnosis, regardless of. So, for example, here in this unit, everyone has cancer. So, in theory, you could introduce palliative care early, and you could have them go alongside treatments that are aimed at cure. So that would be the ideal model, rather than just having interventions, treatments, and then stop, and then your palliative care, because this just feeds into the whole concept that palliative care is only for end of life, which it isn't. So when you're talking about technologies, you can incorporate everything that you have for oncology into the care of children who have palliative care needs, and they can continue to have that treatment. I'm not sure if that's answering your question. Did I understand it right?
Yeah, I think so. And kind of building off of that too, when I think about the medical needs of our patients, they can be quite complex, and having a profound understanding of the different types of medications and management for these complex symptom needs, absolutely there's a medical component to that, leveraging technologies for the complicated use and dosing and strategy of opioids, anxiolytics, analgesics, really thinking through the complexities that are there with the symptom management. And so absolutely, I think that's there. We also talk a lot about palliative interventions from a surgical standpoint, right? Thinking about patients who have pleural effusions or pericardiocentesis, or that need paracentesis for in the setting of fluid collections in their abdomen. That can be incredibly painful and result in suffering. And I work very closely with our surgeons at St. Jude to do interventions to help relieve suffering in that way. And so it is I'm very biased in this as a palliative care specialist and having received that training, but I think that there is a large component of medical complexity in the training that we need to be able to make sure that we are working hand in hand with the oncology team to provide that support for patients and families. There has been this historical view that it's this, we do everything curative, and then when there's nothing left to do, then we move to palliative, and we never say that. There's always more that we can do. We can always still be incredibly aggressive when it comes to taking care of our patients. It's just what our goals are different, and it's, as opposed to focusing just on cure, we're focusing on quality of life as well. And so I think it is very medically complex with the technologies that we use, both from surgical interventions for relief to the medical interventions and the different strategies that we use, thinking about how to alleviate that suffering. And I loved how you used the phrasing integration versus segregation, where it's not that it's one versus the other, but we also, while we're working from this medical standpoint and the doses and the medications and these interventions, we're also working in collaboration with our psychosocial colleagues, with our spiritual care colleagues, with these other teams to be able to work to address the different aspects of that suffering that they're experiencing. And so I don't see it as an either or, I see it as a yes and.
And just to add, I also think it's an opportunity. It goes back to good communication with the patient and their family about realistic goals and expectations. And if you actually can have those open, honest conversations, then it's sometimes possible to stop treatments that it's sometimes easier just to keep giving treatment because that feeds into the family's hope. But actually having those challenging conversations is more realistic and maybe enable them to get home and have good quality of life rather than being treated to the very end of their life. I understand what you're saying about low-income countries. Sometimes those treatments aren't available. So then we often say that palliative care is low-tech but high impact. I have a lot of sayings, but that it's not a very complicated specialty. We have lots of things in our armory, but it's more complex for the person providing the care. But there's not a lot of technology, a lot of expensive treatments. It's more about being open and honest in communication and being realistic with patients and their families and enabling them to enjoy the quality of life that they have left and not keep pushing for more and more treatment. And again, if you're financially, for some countries it's not possible for them to access a lot of very expensive chemotherapeutic or immunotherapy drugs, so that's not an option. And then we have the other issue that there's a lot of this health tourism where people want to go to other countries to see if they can get that kind of care. But this is something, again, if you're realistic with people, then, you know, telling someone, well, if you go to Turkey, you can get this treatment, and them dying in Turkey, is that a good death for the family and for the patient and a good outcome? And is it realistic then to be asking them to go? These are just questions, and I'm not judging anyone on their clinical judgments and skills, but in this world with the internet and everyone's looking at their own symptoms and seeing what's available elsewhere, again, it comes back to being honest and open and making sure that people understand what the outcome is. And that's probably the hardest. It takes so much of your time. And again, that's how many patients can you see, because you have to spend a lot of time with the patient and family. And these are the realistic parts. And how we convey that to ministries and have that written into our policies, we need to look at, you know, who's referred to palliative care and access to the things we need. Because if we don't have access to the medicines and the consults that we need, if they need radiotherapy for palliative bone metastases or something, we need to have access to all of this to help the patient have their good quality of life. So we can't have, so Mike and I have spoken about this. In America, often if you decide that you need hospice, that's a medical choice, and you stop and you go to hospice, so that's really end-of-life care. But in many other European countries, it's the same thing, that you can continue to have your active treatments, but you also receive palliative care. And there was a very good paper by Camilla Zimmerman about this palliative care, the umbrella. So you're introduced to palliative care at the beginning of your treatment, and you go along, but that's always here in case it rains. It might not rain, you might never need palliative care, but when it rains, you put the umbrella up, which is palliative care looking after you, and then you're not surprised and told this is just the end of your life. It's actually there to help you. I hope that answered your question anyway. Thank you.
Please introduce yourself.
Your guests. Thanks for your amazing presentations conducted to what exactly is palliative care unit and its statistics and needs and etc. And I'm master degree student. I want to give you several questions like, can we join to your community as another specialties like oncomamologists or another one like doctors who are in another sphere like infections disease? Can we join like that?
Yes.
Because we have desire to conduct like that project. We have fire in our heart.
Yeah, no, yes, please, everyone's welcome. Yeah,
Yeah,
everyone's welcome.
really?
No, we've had participants in our Global Academy and other trainings and things like that that have been general pediatricians, that have been family medicine specialists, that have been intensive care physicians, neonatologists, infectious disease, cardiology, and so anyone who's taking care of children who are suffering, we're here. And happy to share contact information to join our global community and learn about some of the different offerings that we have.
Thank you. Another question is this also, is this only for pediatrics or for elderly too? If yes, we have ready project to make this kind of project?
Yeah, palliative care for older people. Obviously, thankfully, most people who need palliative care are older, and that represents the biggest users of palliative care services. So, I think if you have good ideas and you have support and you can join, there's so many communities for palliative care. There's the European Association. There's a new Uzbekistani Palliative Care Association. I know that they've set up, so it's a new association this year. The Yahya and Rustam, I don't know if you know them, but they are palliative care specialists here in Uzbekistan, and they're looking at, and Jamila as well. So she's been helping. Yes, and so there's this national association. So this is really, really brilliant news that you're beginning to get this community of learning and engagement, and that's really important for the development of palliative care here in Uzbekistan. And I love seeing young people here who are enthusiastic. So thank you for your questions.
Thank you too.
Спасибо большое.
And lovely English.
У кого есть еще?
Who else has questions?
Можно последний вопрос, наверное.
And the last question, probably,
Как в нашем специализированном
what are your advice? How in our specialized center we could start the work, the organization of hospital-based palliative care team? What should we start with? Can we organize such kind of team here? Who should be in the composition of this team?
Yeah, I think the big thing is having those individuals, like I talked about from our experience, right? We started with a physician and a nurse that most importantly had protected time to do this, right? And to be able to dedicate. So I think from the outset, if you were to have a nurse and a physician who are interested and passionate about this, to protect some of their time to be able to start to do some of these consults. And if they've already gotten training now, and if not, to protect that time for them to go and do some of these courses or training that the WHO hosts, that we host, that other organizations from Russia or around the world kind of have. There's a wonderful library now of different resources to get training in palliative care, both for pediatrics and adult. And so happy to kind of connect in that. But I would say starting with that, and then kind of having that grow over time, to protect that time, to do those visits, to meet with those teams, to work with Rustam and Yahya, and thinking about kind of consultations with Taskin and other kind of resources here in the community. But that's usually kind of how it starts. And I think it's important as well. Some of the most beautiful and powerful, and I want to speak to the nurses here, the most amazing hospices that I've ever seen in palliative care teams started with a passionate nurse. Right, so it's not something that it's just for physicians or it's just for one specialty or other. It's not just for pediatric oncologists. I think if you're passionate about this, you're interested about this, please kind of learn, jump in, and kind of go. But I think what we've seen is the most successful has it been kind of from the start an interprofessional team that has been given dedicated hours in their week and day to be able to go and do these visits and meet with these patients and families and work with the consult teams to be able to grow from there.
And I also think that if you have someone like this, a team who come to the hospital, who see the children who have palliative care needs, and then it's a teaching in itself that you are going back to the person who referred them to you. So if it's if they have leukemia, they have brain tumor, whatever, that team is saying, please could you come and see this patient? They have symptoms, we're not sure how to control them. So you then explain, this is what you prescribe, this is how I would do it. And then the next time the team know, this is how I did it. So it's like almost it grows and you learn from each other. And also there's strong links with the hospice. If you need to refer them, they need extra support. That's really important. But also, even within your hospital, having, I don't know, lunchtime teaching sessions on morphine administration and prescribing, and if you use the resource you have and start to have like small lectures or even breakfast meetings where you can discuss, and that can be both ways. So you can teach the palliative care team and they can teach you. So this is a really strong way to start developing the team. And then if you have any kind of course, or you have people who are interested, young master students, they can go with the palliative care team, and then they learn as well. So this is like it's integrated into everything that you're doing and learning about palliative care every day. And that's, and again, I mean, everyone starts small. The worst mistake you can make is to say you want to develop, everything now, because that it takes time. And I think your last slide was it takes time, right? Thank you.
Коллеги, есть ли еще вопросы?
You got some more questions? Thank you very much. I can see very high interest in eyes of a young specialist. It's very promising. I want you to understand, in this service, it's like a one system. It's like a one big family, because every physician, if I'm not wrong, as I have here from in Seju, they have the system. Every doctor, treating doctor, also serves as a palliative care specialist. Nowadays, in this center, in the system, likewise, we have the same system. Every doctor, they are the palliative care specialists because they serve this service. Yet, I believe they must have a separate specialist as a consultant, because sometimes the doctor himself cannot make the decision that that patient needs no specific treatment, which means that patient it may sound very rough, but the doctor cannot let him go. And here the consultant can help and give the service, let him go. Children, they live longer. Luckily, they can live longer. And palliative support, they can live longer. That's why these patients, they come back, go, they come back and go again. It's like a whole big family. Maybe anyone can serve this palliative care. A doctor, that must be a physician, and next to him, any nurse. If there's anyone interested, not only young people, but we'll start consulting with the pediatric service, because they specialize in the children oncology. The system unfolds in a whole system of pediatrics, and all those diseases will include into palliative care, which means the doctor can serve not only the children with cancer, but other patients too. You need to understand. But the question, do we need a department of palliative care, a separate care? That is the main question. Or maybe in the specialized centers, maybe they need, but close to the remote areas in the regions and villages, we have to find our right path. What do you think? What path do we have to choose now?
Here in an oncology hospital, you should have a department of palliative medicine, in my view.
I would agree. I think both, for the, and it'll grow, right? Just like we talked about, it's not something that from one day to the next, but just as you mentioned, and as I talked about my talk, everyone has a chance to have some basic primary palliative care, but that need for a specialty palliative care provider and team is essential, especially at a unit like this in which you're seeing oncology patients that have a lot of needs and a lot of suffering. Having a dedicated specialty team is really valuable here, specifically, and then that can grow into the community as you grow and kind of take care of some of these other patients. And so I would agree. Oh, specialist beds. Ooh, great question. And so that's where, again, that depends on the system. Where you have the workforce, but then for the beds, as far as the whether you need a specific unit for that. And again, we can just talk about our unique systems, and each system is different. For us, we do not have a separate hospice. We have built into our hospital units and beds that can expand into a larger room if patients and families want to return for home for end of life, or if they want to stay at the hospital for end of life. Or we have a home-based team that goes to the community, that goes to the housing that we have for our patients and families. But for others, they do have a dedicated hospice space. And so that has been effective for their needs in their community. And so I think for us, having those dedicated beds in the hospital have been really helpful for a lot of our patients who they feel comfortable with the team. They know the nurses, they know the staff, they know these people really well, and they know that they're going to get great care in the hospital, where they would be nervous not doing that there. And so then that provides them that sense of comfort to be able to stay at the hospital for their end of life or for their palliative needs. But it depends on the system.
Again, it would depend on the system, and I've seen both models where there's an inpatient palliative care unit with a number of beds, or where you have the palliative care team who have admitting rights. So if, for example, they've seen a child and they're really unwell at home and they phone the palliative care team, then you can readmit them to the hospital, but it's not a specialist unit. So either can work. It really depends on what model you would like to follow. And if you have here already Taskin with 20 beds, and you're able to transfer patients there under the care of a good medical team who have very good palliative care skills, that could be a better option. And you have the palliative care team who are a referral service here and review patients as needed. And then also, hopefully, as things progress here, you'll be able to link in again with the community and get people home, close to their own home, and have their care there.
Спасибо большое.
Thank you very much. And if we speak about the global scale, not just the children, so we have multi-profile clinics, children's clinics throughout the country. The systems comes from the top to bottom to the districts. They also have the multi-profile children's clinics, and they care different diagnoses. Should they have these district clinics, the palliative branch, should it cover the whole clinic, or just for oncology one and one for the rest of patients? What's your opinion? The beds, yeah.
Children. Just for children?
Just for children.
Just
yes.
for children. That's what would you think about them being cared for in district regions and having beds there? If they're closer to home, this is probably a really good idea if they need to be admitted. If you don't if you're not unable to keep the child at home, it's better that they stay close to their own home, because for children, the families still often have other children, they have jobs, the families, and it's really hard for them to come all the way to the capital city to be cared for. So if they can be cared for closer to home, that's better. But families often have very strong views, and they have very strong links to the hospital that sent them there in the first place, and they want to come back. So I think it's almost, that's another step down the road, I think, and you'd have to think about how that could work. Would you have, are the oncology services in those district hospitals equal or similar to the ones they would get here? That would be a question the families would be asking, I imagine, rather than coming back to the referral centre.
Yeah, no, I would agree that the opportunity to have the patients closer to home, to be where they want to be, I think is the key. And if that is something in which that district oncologist can provide those resources and support for the family to be closer to home, I think that that's a great model. I think, and it all comes down to, we've seen this shift where it used to be, the data, we want everyone to be at home. And what we're seeing is that that's not always the case, but having the opportunity to have them closer where they can get the care that they need and the medications that they need, that makes sense.
She's talking about sort of secondary. Yeah.
Mm-hmm.
Yeah. Did we answer?
Thank you. Yeah. Thank you so much.
Коллеги, какие вообще вопросы?
Colleagues, any questions?
Если вопросов нет. Sorry. Есть, оказывается. Давайте.
Good afternoon. I'm the first year resident here. So I want to ask a question about the emotional burnout of the amongst the palliative care specialists, because I think it's emotionally hard working here, like as an oncologist or hematologist, because it's always hard seeing how your patient is when it's in pain. But what is when every your patient is in pain, and how can manage it?
Yeah, so thank you for asking this question. I think that this is such an important question and something that we're seeing around the world, just this feeling of burnout, of compassion fatigue, of moral distress. What has been interesting is that when I think about, we talk a lot about the prevention and relief of suffering, I'm starting to broaden that to not just patients and families, but our healthcare professional teams as well, and recognizing that we suffer when our patients suffer, and how we can take care of ourselves. One of my close colleagues wrote a paper about that we grieve too. When our patients die, we grieve, right? That the loss of our patients. And so it is essential for us as healthcare professionals to take care of ourselves so that we can take care of our patients, and how we can care for them without carrying that burden. What has been really interesting in the literature is actually, in some of the research that we've done, is that actually having palliative care training and having those skill sets to relieve the burden of suffering of our patients and families is actually protective for us as healthcare professionals ourselves. We've done a study that has looked at oncologists and how they feel with being overburdened by the suffering of their patients. And those with the palliative care background actually felt less burdened than those that did not. And so having some palliative care training does provide a protective effect, where we know that not, as even in 2026, with all the incredible advancements in medical care, many of our patients do not survive their disease. And if we can have the skills to help keep them comfortable, to help take care of their parents and their family members and ensure that they have lived a life of dignity, it does help us. And so some of the evidence regarding burnout, it's actually less in palliative care professionals than it is in not other professionals. And a lot of that, we're still trying to figure out why, but one of the theories is the fact that we've developed skills to help take care of these patients in a way to provide dignity and respect. But still a lot to learn in that space, and an area that I'm particularly passionate about.
Thank you, but do we have some support system for them, or how we know for sure?
Yeah.
They have, like, how they feel as a doctors.
As doctors, so we are doing research in this space, and we've developed some systems for resilience. We have at St. Jude, we have what's called our Resilience Center, and we have kind of opportunities for training in that space, and it's definitely an area of growing research in that. But what we are seeing, at least in the evidence in some of the work that we have done, is that having palliative care training and supporting and having that, it does provide a protective effect against burnout. And I will say, it doesn't completely prevent burnout, right? Like there are times in which I have patients that go through difficult experiences, and it's really hard. And what we do is really hard, and to acknowledge that and to recognize that and to recognize how we can take care of ourselves and take care of each other. That's the other really important system when you think about and understand that burnout is a systemic issue and not an individual issue, and how to be able to create systems to be able to support each other in that is really, really important.
I think as well, I've seen a lot of research presented at various conferences that I've been to around nurses and burnout in palliative care, about doctors and burnout. And it seems to be that quite often it can be what's going on in your life can be difficult too. But I think all of us as healthcare professionals take patients that we've cared for through our lives with us, and we think about them still. I don't think you ever forget that. But I think working in palliative care, because we have this team approach, and I'm not saying everything's perfect in palliative care because it isn't, but if you see your colleagues are having problems, then it's something that you can support each other, and I think that can help. But I also think if you don't have the tools to help families, and you're seeing families who have a child who's dying in pain or an adult who's dying in pain, then that's far more distressing than if you're able to help by providing and prescribing the medication that they need that we know works. And what I see here in Uzbekistan is that there are a lot of restrictions on prescribing. And in my presentation I showed you have very low consumption of opioids. We know opioids are the drug of choice. They help with cancer-related pain. We need to prescribe them more, and we need to know how to do that. And it's much less distressing to care for a patient when their pain is controlled than if it isn't. And I think some of these issues, with more training, more education and support, I think we can help with that. And I hope you're not too burnt out or distressed.
Thank you.
Thank you very much. A very relevant question, the syndrome of burnout, especially among those working in our area, in the palliative support area. So, colleagues, any questions? If no questions, then I would like to thank you, everyone, for your participation and interest, and would like to share my gratitude to our international experts for very informative presentation. And we started with organizational structures of palliative support till the staff training, and I think that this meeting will bring on positive outcomes, and our young specialists, the residents, so they also already have some projects in mind. And I would like to thank one more time everyone and wish you good luck. Thank you very much.